and welcome to Health Matters. I'm Dr. Jack Jolwitz, a board-certified skin doctor and skin cancer specialist. But today, I'm your host. Great strides in medicine occur because of the dedicated physicians who do research. They carefully monitor the patient's response to new medications, and if all goes well, these new treatments get approved to benefit everyone. Today we have as our guest Dr. Al McKelvin. Besides being a board-certified neurologist, he's one of those great physicians involved in research to make those treatments available to all of us. This is Dr. McKelvin's second time on Health Matters, so let's welcome him. Al, welcome to Health Matters.
Thank you, Jack. I've been practicing neurology in Bradenton for over 30 years, and our neurological practice in Bradenton is Bradenton Neurology. In the early 1990s, we started doing some clinical trials. At that time, I believe, for Alzheimer's was the first one we did. But over the years, we've expanded to include epilepsies, neuropathies, multiple sclerosis, and Parkinson's, to name a few.
I know you've also done some on Herpes Zoster because I've gotten some of your notices about that.
That's true. We've done, actually, there's a new drug that was approved last year, I believe, called Qutenza, which we did the original studies with that one as well.
So you've been doing research for 20 years now. Is that like your passion?
It's very interesting because a lot of the neurological conditions we diagnose but don't have a lot to offer. And when we have a new treatment that potentially helps patients, it's very rewarding.
I'm sure it is. Well, let me, I know we're going to be talking about Parkinson's disease today, and we've all heard about Parkinson's for a long time. It's a very well-described phenomenon, and I know you have a lot of interesting things to teach us about Parkinson's. Why don't we start by teaching our viewers what exactly are the signs and symptoms of Parkinson's, and how do they know they might be having those symptoms?
Actually, the diagnosis of Parkinson's is probably made on history and examination more than on any other test. If we do any brain scans, for example, it's done to rule out other conditions. It is a slowly progressive condition, so early on the patient may just notice a little bit of tremor in their hand and not think too much about it. Other patients may notice their handwriting gets much smaller. As the condition becomes more pronounced, there's a slowness of action. It takes the person longer to do routine tasks around the house than they used to do. They can then develop some postural instability with difficulty getting up from a chair or turning over in bed. They can lose their balance and fall backwards.
Are these gradually more noticeable to the patient and they just say, I wonder what's going on, or is this something that suddenly, all of a sudden, I'm different?
It's usually gradual, and if you go back and ask somebody, they may have, now that you mentioned it, my handwriting hasn't been doing well for a couple of years, and they will generally recognize the tremor. In fact, we have a lot of people with essential tremor, which is not Parkinson's, come in because they're afraid of Parkinson's because they have a tremor. It's a different ball game, but those patients usually come in with tremor are the ones that come in early. As they start getting more trouble with their balance and walking, they may develop a slow shuffling gait, and family members may be the ones that say, hey, something's wrong with your walking. So they come in at that point.
So the most common sign that someone comes to your office is the tremor, or what brings them to your office as a neurologist?
Either the tremor or the change in balance that they're having.
After a fall, they would be?
They may be falling more. They may notice that they have a kind of a running gait. They come up to a curb and they trip over it more because they're not picking their feet up, for example.
So it's like they're slowing down, their movements are slower, is that?
Exactly. It takes, the bradykinesia, or slowness of movement, is one of the hallmarks of the condition.
So
it
it's
takes
like
them longer to get their arms in their sleeves, button their buttons, prepare meals or whatever.
So everything in their life just takes longer, and it becomes more of a deliberate action.
That's correct.
And they notice this. That's
Yes.
what they notice.
That's usually
that
what they
I'm
notice.
not as young and spry. Is that what they would say?
Some of them just say, I'm just getting older. And family members say, no, you're not. Something's
There's
different.
something on, and
Right.
we need to find out.
They may lose voice quality, becomes more of a monotone, low-pitched voice. And it's like, speak up so I can hear you.
Do they, does it affect their thinking? Or is the thinking still good?
Usually in the early stages, the thinking is still good. Later on in the progression of the condition, there can be a dementia associated with it.
Okay, but not typically in the beginning. They've already, by the time the dementia would happen, they would know they have Parkinson's usually.
That's true, yes.
Okay, so now what causes the slowness to happen? What causes the muscles not to be as quick to take these steps or get up or keep the balance?
Well, Parkinson's is what we refer to as a movement disorder, and it's a neurodegenerative disorder. And it is characterized by loss of a chemical neurotransmitter we call dopamine. And on slide 1, we'll see an area of the brain called substantia nigra, which means black substance. In the normal individual, it is black. As the person gets Parkinson's, it becomes more pale, indicating loss of the dopamine transmitter.
So actually in the brain, there's a dark spot in the brain that makes this dopamine, and it doesn't make it in Parkinson's. It's missing.
When a person gets symptoms of Parkinson's, they have lost about 80% of their original amount of dopamine that they had in their brain.
Really? And this was the first discovery, and so we've known about this like 100 years?
Well, we've known about it for many years. There was a movie, I think, in the late 60s called Awakening, where they showed patients with this rigidity, which is basically Parkinson's, and treated it with L-Dopa. And that's the mainstay of treatment even today.
So that was a breakthrough back in the 60s, that was the first treatment for this.
There were some other treatments beforehand, but this was really the best treatment at that time.
So before the 60s, without good treatment, the people were just frozen? What would be the end point?
A lot of patients became just very rigid and were frozen. There were some other medications like Artane that we were used that worked on a different chemical, amantadine, which was actually a flu drug that they found worked in Parkinson's, but they were limited. And so really L-Dopa, which later came out as Sinemet, was the first good drug for treating it.
So L-Dopa was a drug that's 50 years old now. It came out and it worked and it got people moving again with Parkinson's.
And it's still being used.
It's still is this like the best drug if you had to pick one drug?
As far as the effectiveness of the drug, Sinemet, which is L-Dopa plus carbidopa, is the most effective drug out there for it. It has its problems, but it's still the most effective drug as far as response now.
So for 50 years, we haven't found anything really better than that drug?
Not better, no.
Not better. But you're going to tell us about something new in a minute. Now, you've been doing a lot of research, and you've done research on Parkinson's in the past. What drugs have you worked on with Parkinson's in the past?
We've worked on one of the drugs that's out there on the market is called Mirapex or Pramipexole. It is what we refer to as a dopamine receptor agonist, which it acts like it's dopamine when it's not.
But it's not better than the L-Dopa?
It has some advantages in that its half-life is longer, it stays around longer. It has some disadvantages in that it is not as effective, I don't believe, and it has more side effects such as hallucinations and dizziness when the person stands up.
So we still don't have a really great drug. Out of all your patients, you're a neurologist, a board-certified neurologist. You see every neurological disease, motor diseases and whatnot. What % of your practice is Parkinson's, to give us an idea of how prevalent this is in the community?
Well, in the United States, there are probably 1 million cases of Parkinson's, and there are probably 60,000 new ones every year. Over the age of 60, about 1% of the population will have it. Over the age of 80, about 4% will have it. In my practice, it's probably about 20% of my practice.
Okay, and that's probably because of all the research you've done. I would think you'd be considered an expert on Parkinson's.
We try.
Okay, well, why don't you tell us, I know you've got some research projects ongoing, and as part of our discussion today, are the community, are these projects, these research studies open to patients in the community that we're going to be talking about? If somebody has Parkinson's or thinks they have Parkinson's or is on medication now and not doing well, are these studies open to anybody to be evaluated by you?
Certainly. There are certain, what we refer to as inclusion and exclusion criteria that the person has to meet, but if they meet those, they're open to anyone.
And then they would come in and you would do an evaluation, and if they met these criteria, you would explain everything that you know about the study, about the drugs, so they have fully informed consent to
certainly.
Participate with
I
these.
tell them about the drug, why we think it should work, what the benefits could be for them. A lot of these studies are what we call double-blind placebo-controlled trials, which means that one group gets the drug, one group does not.
And you don't even know which
I don't
group.
know, and I don't control that. I've tried to talk them into sending me the drug patients and the placebos to Tampa, but they don't really want to do that.
So you don't know, and the patients don't know, so a patient may actually be getting the same drug they're already on.
That's true. And in fact, one of the studies we're going to be talking about, it's called a double-blind, double-dummy study, and I don't know if they mean I'm the dummy, but but one group gets the gets a placebo pill, one group gets the medication, the other group gets just the exact opposite. So it's actually two forms of treatment in that study.
These studies have become, these study methods have become so sophisticated because they really want to try and find out if the drug is truly effective.
Yeah, and there is such a placebo effect with drugs. If I tell you that this drug is the greatest thing since sliced bread, and I can probably sell it on you, and probably 40 to 50% of patients are going to believe that. Now, in my practice, if they get better, I don't care. But in the case of research, you really want to minimize that placebo effect because you really want to know what the actual effect of the drug is, as well as the side effects of the drug.
So it's so important that everybody follows all the rules very carefully, and
Exactly.
and that's where you get a real honest answer at the end of the study.
That's correct.
All right, well, why don't we start and tell us about the first study you want to talk about. And I know this is involving that L-Dopa drug that's 50 years old that we've been using. Why are they studying that now?
One of the problems with L-Dopa, as I mentioned, there were some problems earlier with it, is that it has a very short half-life. That means that when I take it, it gets into the body in 30 minutes to an hour, but it's generally gone by 2 to 3 hours. So it has kind of a picket fence effect, so that it gets in, it gets out.
So you get blood levels going up and down throughout the day. So is it a drug someone's supposed to take 5, 6, 8 times a day?
Well, usually we don't, because the body is able to store some in the brain, and therefore it keeps a more constant level of dopamine. But as the person gets more advanced, the body doesn't store the drug, so the blood levels tend to mirror the dopamine levels in the brain, which then give an irregular firing. So instead of a normal firing pattern of the neurons, you get fire, fire, stop, fire, stop, fire. And
So it's a more
erratic.
Okay.
And patients with that condition, when that happens, will take their pill. Sometimes they'll get too much of effect, and instead of doing what they want to, they start having what we call dyskinesias. They'll do okay for about an hour, and then all of a sudden, within sometimes matter of minutes, but certainly over 30 minutes, the drug goes away, and now they're rigid and they can't move.
So they'll go from rigid to moving to too much movement to rigid, and it just is not an easy lifestyle to maintain.
That's correct.
So that's the big problem with the drug since 1960.
Yeah, that's correct. And so this involves placing a tube through the skin wall and having one of the gastroenterologists snake the tube into the small intestine. The end of the tube it remains outside of the skin, and there is a little pump that connects to that, and it gives for 16 hours a day a constant level of dopamine that we can control the rate depending on the person's symptoms. So instead of the ups and downs and picket fences, we get a constant level of dopamine through the day.
So you're constantly infusing the dopamine while the person's awake, getting a constant supply into the stomach or
the small intestines, actually, right,
where it's absorbed. So you get a constant absorption level, so you get a constant blood level, so you get a constant brain level, and it just keeps that person on an even keel without that spiking phenomenon you were discussing.
And that's the general idea of it.
But it's the same medicine from 50 years.
From 50 years, except it's now in a gel pack instead of in a pill.
And this will solve the problem of the dyskinesias and the spikes and the freezing and the lifestyle effect.
That's, if it works as planned, that's exactly what happens. And it's been available in Europe for a while. And at some of the meetings I went to, they actually showed a picture of a man who was very poorly functioning in his daily activities with this on off. And then they show him snow skiing with this pump.
Really?
Really.
And now where does the pump? The pump goes attached to the
pump. The pump has a little fanny pack to it. It just sits in there.
It sits there.
Right.
It sits in the fanny pack, and the tube. It's not a big deal to put something through the skin right into the intestine.
Right. That's actually been probably one of the major complications of it. Obviously, is skin infections, the thing pulling out, and that sort of thing. But
they've finally got that.
It seems to be manageable.
Well, this sounds like a huge breakthrough if and when it becomes available. And since this drug is already the same drug that's been approved, we already know all the side effects. We already know all the downside.
This is just to
it's just a delivery mechanism.
To eliminate one of the downsides of it.
Now, if somebody is already on medication, can they still talk to you about becoming part of this study?
Certainly. In fact, this study has a rather complicated titration phase where they go from their present medications to this group, and it'll be, again, this is a placebo trial, so one group stays on what they are, one group stays on the pump, and at the end of I think it's 3 months, they all will go into the study.
They all go on
the pump itself. It may be 6 months. But
so the first few months they're going to just continue. One group will be no change.
One group will be no change, but they'll have the pump, and at the end of the evaluation time, everybody will then go onto the gel.
But it's not a study where they would just get placebo in the pump.
No.
Everybody gets the medicine.
Eventually, everybody gets the medicine in the pump.
Everybody gets the medicine. Right. And then they can compare their previous function to their new function.
Right.
It sounds wonderful. And are you now beginning to enroll patients?
Yeah, we've done 3 patients, I believe, thus far already.
And so far, so good?
So far, so good, right.
And they're happy to carry these fanny packs around to get the benefit of that.
Right.
I know you're doing other studies. What else have you got in your Parkinson's armamentarium there?
One of the problems with Parkinson's and some of the medications that sometimes patients develop hallucinations.
Now, the hallucinations, it's not dementia, it's it's medicine related.
They will have a normal mental status or close to it, but they will have hallucinations. I always remember one when I did a study many years ago. I was giving very high dosages of the study drug, and for 3 visits, the husband kept complaining of hallucinations, and the wife was looking great. Finally, I said one day, "She's mentioned the last 2 times about these hallucinations. Ms. Jones, tell me about the hallucinations." "Well, quite frankly, he's gone all day playing golf. They keep me company. I rather enjoy them." So they're not really scary hallucinations, but they're there.
For those in our audience, a hallucination it's a visual
It's a visual thing. They may see children that are there. They may see
they see things that are not there,
and
but
not
to them,
threatening.
Do they know they're hallucinations?
Usually they do.
So they know that they're seeing something, but they know it's not really there.
Exactly.
And this is part of some of the side effects of treatment.
If you think about one of our other hallucinatory mental conditions like schizophrenia, they hallucinate, and we treat them with drugs like Haldol and Thorazine, which work to block dopamine. So if you're giving something that acts like dopamine, it stands to reason that some people can get hallucinations.
I see. So this other study is a drug that will reduce the amount of hallucinations.
This particular drug works on serotonin receptor sites rather than dopamine receptor sites. So it does not affect the dopamine, which has to do with the movement disorders, and hopefully will help the hallucinations in those patients.
Oh, I see. So they can take it along with their Parkinson's medicine.
Right.
So it's an additional medicine.
It's additional medicine.
And so is somebody a candidate for that who is having hallucinations while they're on their treatment for Parkinson's?
That's correct. Those are the patients that we're looking for that.
And how often does that happen in the treatment of Parkinson's?
Probably 10 to 15% of the time.
So it's
not that unusual.
It's a significant amount that somebody comes in and they need medicine for the Parkinson's to loosen them up, to get them moving, and they get the side effect of the hallucinations.
That's correct.
And now you're testing this other drug to see if, in addition to treating their Parkinson's, we can stop the hallucinations.
That's correct.
I guess the hallucinations in your lady weren't so bad.
No.
But in most people, they would find them discomforting?
Usually they don't. I had one that the only problem was he kept seeing little boys fishing, and then one day there were some little boys fishing, and he
wasn't sure
what was real or not. So that's the other thing.
It's got to be tough. I know you're also doing some new research on a new, totally different new line of medicine.
We've talked about dopamine, and everything in the brain is a balance. So you have excitatory and you have inhibition. It's kind of pluses and minuses. And in Parkinson's, with it being a excitatory neurotransmitter, when it gets too low, the inhibitor is a little stronger. So the other ways of bringing that are to, one, increase the dopamine, as we've tried with the dopamine. This new drug works to try to block the inhibition so that it brings those back into
a balance.
More of a balance. And it's what we call an adenosine A receptor antagonist.
And this is not approved for Parkinson's.
Yeah, this is not approved.
This is a whole new
this is
line
not approved. There's
research.
actually no drug like it on the market. The closest thing is probably theophylline that they use for respiratory issues.
That's for asthma, to open the airways.
But that's a non-selective antagonist, whereas this is selective just at this particular receptor, which is only found in the area of the brain that has to do with Parkinson's, which we call the striatum.
So this is a very specific theophylline-like medication that just works in the brain.
Just works in the brain and in this one specific area in the brain.
It's amazing that they can find medications that's so specifically targeted.
Yes, it is.
Now, this is considered a phase 3 study.
That's correct.
That means the phase 1 study is where they just do it on animals?
Well, phase 1 studies are actually done on humans, but they get a few healthy volunteers, and they give them the medication, and they try to figure out from there if there's any untoward side effects, what the dosages should be, what the blood levels are at various times. Phase 2 studies are done are a little larger, but they're done on patients, and they're done for safety reasons. You usually don't have enough power in those studies to determine if they're going to be effective or not. Phase 3 are studies when they've gone through and they believe they are safe at this point, but they don't have enough data to say.
So we already know the drug is safe. We believe it's safe based on the phase 1 and phase 2. And now the phase 3 is to find out whether it really will balance the brain and how well it will balance the brain.
And yes, and those are usually much larger studies because they have to have more people to do that.
Okay, so you're looking to enroll a lot of people, but if someone's doing good, should they participate in these, or
if somebody's doing well and is totally functional, they're tolerating their medications, they're not having problems with it, then there's probably not a lot I'm going to offer them as far as benefits are concerned.
You wouldn't offer them to be in the study if they're doing well.
Yeah, and these studies are generally looking for people who aren't doing well. They're trying to show that the patients who were on standard of care treatment are better off on their drug than they were on standard of care, and if they're already doing well on the standard of care, doesn't do a lot for that purpose.
Looking at all comers with Parkinson's, and you put them on the standard treatment, how many people are in that category of not doing well that might be a candidate for one of your studies?
Most patients, when you first see them, the early ones we talked about earlier, are going to do well. They're going to do well for 2 or 3 years, sometimes longer than that, 5, 6, 7 years. Eventually they will.
So eventually they all don't do well.
Eventually they will all start declining to the point that they need other forms of treatment.
I've learned so much today talking to you about Parkinson's. Time is short. Any final thoughts on the direction of treatment to get to that functionality, which is the end point of all these drugs?
Well, there's been a lot of research on Parkinson's in the last few years, some of it having to do with brain implants, some of it with the medications we've started. The goal is really to keep the patient functioning. Patient can do a lot for themselves by exercising, keeping their body strong, strength exercising, cardio exercising. So between that and the medication, we can keep most of these people very functional.
And you explain all this when someone comes in, what their best chances are to do the best, the longest.
That's correct.
I want to thank Dr. McKelvin for his dedication to the people of Manatee County. He treats all neurological conditions, but he goes the extra mile to do the research that will help all of us in the future. I also want to congratulate METV for winning the Manatee Community Foundation's Collaborative Spirit Award, and thank them for producing today's show. And I want to thank you, our viewers, for watching and learning. If you have Parkinson's or know someone who may be a candidate for one of Dr. McKelvin's studies, please call him on the number posted on the screen. I'm Dr. Jack Jawitz for Health Matters, reminding you to always wear your sunscreen and your seatbelt, because your health matters to me. Thank you.